Good morning.
Good morning. See, I'm over here scrolling. I done got caught up. I said, well, where are we? Well, there we are. How are you doing?
I'm great in yourself.
I'm good. How was your week?
Good.
Good. Are you blending, sir?
Am I what?
I said, are you blending?
No. I set the phone down on my iPad and it started playing the video that I had paused.
Oh, you know they all connected. They do all kinds of things. I'd be like, really? What is happening? Why are phone calls over here and stuff over there? It does all of the things. It's a wonderful problem to have. How about that? But your week was good.
Yes.
Good,
How
good.
about yours?
Busy, busy, and even more busy. Yeah. But it's I'm trying to do all of the things to prepare for look the winter.
Right.
To prepare for my my getaway to Macon because the baby's coming in December. So
Okay.
yeah, trying to get everything, make everything. Yeah. But yeah, good information. Learn some things. You know, it's my students teach me something every day. I'll just say that.
Okay.
They teach me something new every day. I'll be like, really, really. So all good. Yeah, yeah, all good. All right. Well, let's get this train a rolling. This teapot whistling. This all
There you go.
all of the things. Well, welcome to our Saturday morning tea. Here we brew up the hottest topics in healthcare and we discuss health information, news, education, certification tips, entrepreneurship, how busy the week is, uh, how living without and with Apple products can be problematic. All the things. But more importantly, the revenue cycle at large. And as you come in, don't forget to hit the thumbs up or like button. I'm Clarice Warner. I'm the girl with the pearls. I'm the founder and senior education director of the Professional Reimbursement Network LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, the heart of it all. Yes, that specializes in revenue cycle and regulatory compliance and education. Now, let me ask you, do you know what it takes to be a certified, marketable, emphasis, marketable medical coder? Do you? Well, before I introduce my co host, let me share with you information on a free, yes, free 99, free for all those in the world, free email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. Hey, okay. You see, I was dancing. I've been dancing all morning.
Good.
It's been a happy morning.
There's nothing
Started
wrong
at
with
4
having a
a.m.
there's nothing wrong with having a song in your heart.
Hey, and a two-step.
There you
Hey.
go.
So if you're interested in getting more information about the 5 steps to become a certified marketable medical coder, check out the video description for the link. Joining me today is my partner in success. Yes, my co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I transitioned away from bedside nursing into medical coding in 2014. In 2020, during the pandemic, I created a company, the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
Ooh, and what a wonderful world it is.
It really is.
It is. It is. I had a conversation just the other day about all the different things that you can get into. And this, the guy was talking about, of course, IT. A lot of men love IT, but he was talking about, I think it's the tinkering or fiddling, but not.
Right.
But he was talking about IT and all of the things, and I was like, but you can parlay your health information education over into IT, like electronic medical records, workflows, protocol, all of those things that the computer is now assisting with it, which is the tool that requires IT to help operate it. You can add to. You can be beneficial to. And he was like, "Oh, I never thought about that." Well, absolutely. Expand your mind. Free your mind. Expand your mind. Okay. So yeah, all those things. I was excited for him. All right. So you gotta say something?
I
No.
was just going to just, the problem with all of this is, and I've talked about this extensively on this podcast, but AHIMA and AAPC do a terrible job of marketing because it's there's no reason with all that's going on. Everybody that has anything to do with HIM, they should be inundated with inquiries because it's a whole lot going on.
It's a lot.
And you can find there's HIM is so vast. You can do so much with it. But if you don't let people know how they can, how are they going to know?
Right. And I don't know, a lot of people think, oh, it's just a little person in a box in a corner, flipping through some files and HIM, medical record librarians, all of those terms from the past. But baby, we have expanded a whole lot. We do a lot, all throughout the revenue cycle. And you'll find us everywhere throughout hospital systems, physician practices, payers, government guidance, IT, public health, everywhere, research, all the places. We are everywhere doing all the things around health information. If you think about how vast and how wide just health information is, that should allow you or let you know that we out here doing all of the things without we play with everybody. We play with everybody. All right, y'all. So before we jump in, let me remind you that you can join in and add to the conversation. Don't be shy. Don't be shy. Your opinion matters and is always welcomed here. Even though you may be contrary to what we're speaking about, we still welcome and value your value your opinions. So please, friends, use the chat. Use the chat. If you have a question, please type Q first so that if you have a question for us, please type Q first so that we know that it's a question and we don't miss it. I know you all like to talk and chat amongst yourselves, so have at it. So, for those who are joining us today or watching the replay, today we are talking about compliance. So, this yogi stash blend of tea I got today is for real the business, the business, just like our topic today. And really, we're going to look at just billing, billing compliance for primarily physician practices because we've talked a lot here on the show, and it's quite apparent that there are a lot of things that are not taught in schools for these providers. And we beat up on physicians and whatever because it's low hanging fruit. So in medical schools, a lot of these things aren't taught, but we have multiple provider types, and clearly this stuff is not taught in their education in their schools either. So we want to talk about billing from a compliance perspective and how that can help you as you are operating in your practice. So before I get to that, let me also tell you my quotes of the day for my tea. So the first one is, even a journey of 1,000 miles starts with a first step. Just one. Just take that first step. And then the second one, because I have two of these. I got it's a strong brew over here. I got 3 tea bags in here. The second one is, you are unlimited. And yes, you are. Okay. So before we get into all things compliance as it relates to provider billing, let's get into our church announcements, shall we? Uh-oh, look, you ready. Ready. Hey. You got the slow bop. Hey. I love it. Okay, okay. So today's church announcement is actually brought to you by our on the street correspondent, the Crafty Coder. Yes. So from the American Society of Anesthesiologists, they put out a blast. They put out a press release, and they were like, wait a minute, everybody needs
On
to
mute.
know. Right. So the article is, Anthem Blue Cross Blue Shield won't pay for the complete duration of anesthesia for patients' surgical procedures. Where they do that at? I guess at Anthem, Blue Cross Blue Shield. And it's another example of insurers putting profits over patients. I don't think they actually have a person. Wrote the article. No, it's just from the American Society of Anesthesiologists. So basically, Anthem Blue Cross and Blue Shield plans representing, and it's 3 states for now, I guess, Connecticut, New York, and Missouri, have declared it will no longer pay for anesthesia care if the surgery or procedure goes beyond an arbitrary time limit. Take your time if you need to. Have a surgical event if you must. But you might be feeling that knife. You might be feeling the saw. You might be feeling all kinds of things. If they don't hurry up, production, stitch you up and get you on. Again, regardless of how long the surgery or procedure will take, they are planning on no longer paying for it if it goes over. And the American Society of Anesthesiologists calls on Anthem to reverse this proposal immediately, and rightfully so. Again, anesthesiologists provide individualized care to every patient. We all know every patient's situation and circumstance is different. Everybody doesn't necessarily react to anesthesia the same way. Other health conditions can play a factor in the types of anesthesia or the efficacy of the anesthesia being used. So it's a whole bunch of things that anesthesiologists have to take into account when they decide, the anesthesia that will be used for a particular type of surgery. And also, conditions that patients have can play a part on how and the way in which that surgery or procedure may happen. Something can happen based on, other factors. They may start the surgery and learn there are other things happening and they need to address that first and do so there's a whole myriad of things that could potentially cause a procedure to start one way but end some other kind of way, if you will. So what they're saying is payment for anesthesia services, again, is based on several factors, including the exact amount of time for anesthesiologists to deliver care preoperatively, during the operation, and when transitioning the patient to recovery unit afterwards. However, with this new policy, Anthem will arbitrarily predetermine the time allowed for anesthesia care during a surgery or procedure. If an anesthesiologist submits a bill where the actual time of care is longer than Anthem's limit, Anthem will deny payment for the anesthesiologist's care. So with this new policy, Anthem will not pay anesthesiologists for delivering safe and effective anesthesia care to patients who may need extra attention because their surgery is difficult, unusual, or because a complication arises. And you had several anesthesiologists speak out on this, and physicians as well. One such, Dr. Donald E. Arnold, says this is just the latest in a long line of appalling behavior by commercial health insurers looking to drive their profits up at the expense of patients and physicians providing essential care. It's a cynical money grab by Anthem designed to take advantage of the commitment anesthesiologists make thousands of times each day to provide their patients with expert, complete, and safe anesthesia care. This egregious policy breaks the trust between Anthem and its policyholders, who expect their health insurer to pay physicians for the entirety of the care they need. So the American Society of Anesthesiologists urges people concerned about Anthem's proposal to contact their state insurance commissioner or their state legislators. Also, keep in mind, in June of 2024, Elevance Health, the corporate name for Anthem, reported a 24.12% increase in its year-over-year net income to 2.3 billion, and a 24.29% increase in its year-over-year net profit margin. Just a little additional tea to add to the situation. Mr. Jesse, did you have any comment on that?
I'm just wondering, like, I understand that people have contracts, but why don't they just not renew their contract with Anthem when it expires and just don't do just because once those people run out of places to go to have surgery, Anthem will realize, look, we got to pay because our people can't be treated. I mean, it's no sense. I mean, it's ridiculous, but this is only just going to be the beginning. So there's going to have to be some kind of strategy. And I just don't think that, trying to fight back afterwards. I think people have to be proactive. When these contracts expire, just don't even renew it. Just don't even take Anthem, and just don't even be. Let Anthem worry about and having their patients chew on some bark while they're having surgery, like they used to do back in the day. They give them some liquor and something to bite on.
You are absolutely correct. I think education, information needs to go not only to, and I'm thinking, so in a corporate environment, say your employer uses or has a contract with Anthem, making sure those who are at the table that make these decisions on which insurer or which health plan the folks go to is important. I think, again, this information should go, particularly in these states, but I mean, it may start here and trickle through others. So making sure that folks understand, what this looks like and what it could look like for people when they are negotiating those contracts, and then letting the employees need to make sure those folks in HR and whoever is sitting at the table negotiating these contracts for these commercial payers know, but then also folks abroad need to know, and then the folks sitting at the table need to also let the employees know, okay, these are kind of the options, and have multiple options. Oftentimes you're in these companies, they no longer give you multiple options for choices. They'll give you options within a plan, but they don't give you multiple plan choices anymore. It's crazy out here because you really don't know. You're at the mercy of the people in HR or whoever it is that sit at the table to negotiate these contracts. You're at their mercy on what type of contract or plan it is that you get, and it's crazy. It is crazy.
Right.
Crazy. Good morning, Tanika. Good morning. Good morning. She says, so they just gonna pretty much let folks die. Like, so dumb, so dumb. Like, how you gonna tell these people how to anesthetize a patient? Just make sure the documentation matches the time or something. And she's like, what the what? Yes, this is crazy. Crazy.
It really is.
All right. Well, that was our church announcement. Sir, I know you got a church announcement.
Actually, I have two.
Oh, wait, what? Well, wait. Yes, sir.
I have my ICD-10 CM class starting Tuesday, January 7th, 2025.
Yes.
And I have
Uh-oh.
It is so interesting, like how people, like, I understand that you have people when you're in business, you always have people who want to kick the tires, so to speak. And they want to ask you all kinds of questions. So I had this, someone has been asking me a lot of questions in response to, like, they sent an inquiry, I sent them information, and I let everybody know that you can have a complimentary consultation.
Okay.
So it's just question after question, and I'm like, so I had to finally just tell them, I'm like, this is the last question I'm answering via email. I have told you that you can have a consultation. Just schedule a consultation to ask your questions.
They tried it.
Exactly. But you just have to,
sometimes you got to pop out and let them know. Show them something.
And if somebody's saying you can have a consultation, just ask, that's what a consultation is for. But
your one-time shot to get it all in.
To get it all in.
That's small time. Now, anything after that, time is money.
What about this? And what about it?
Why did I hear you doing that? Like, what about it? Is there anything else I can assist you with? Here's the link.
I don't get it.
But anyway.
Because I really, and I understand. I understand people. You should have questions. I'm not saying
absolutely.
That. But it was when somebody's offering you a vehicle, because what I know for sure is I know that you're not sending AAPC 72 questions, because they don't even. They're going to refer you to a website, or they're going to just ignore you. But they're not going to. You're not going to waste their time. So anybody, when somebody offers you a consultation and it's complimentary, take it. Write your questions down and just do a one-stop shop.
That's some tea right there. That's some tea. That's right. And, be respectful of other people's time. Be respectful. They're offering you undivided access to them for whatever the consultation time is. Again, use that time for what it is and be prepared during that time. Yeah.
And also one more thing, I have noticed that now, like, since I'm on other platforms, there it seems to be an uptick in nurses who are asking about medical coding. And
you're gonna make my nostrils Everybody know my nostrils will spread. You're gonna make my nostrils spread, sir. Go ahead.
And there was a post on LinkedIn by what was her name? Blue Garcia, Coding with Blue. Mm.
Mm-hmm.
So I think there was a nurse who had posted a question because she was talking about the CCDS and how it said that is recommended or required, like you have 2 years coding experience. So she, so Blue responded, yes, Tanika. So um, this woman was so Blue responded, about she's very diplomatic, but I do like her because she's not afraid to talk about things. So me, I comment and I'm like, well, we know that RNs have cornered the market and gate kept CDI, and
The floodgate.
right. I just
Did
think
you
that
break the internet?
no, not really, because pe- people ain't about that life. They ain't really trying to call a thing a thing.
Ah, my sentiments. Exactly. Well, go ahead.
You know, but but there needs to be a real conversation about it. And then I was in the medical billing and coding forum Facebook group, and a nurse came in there, and you should have seen the the comments. I'm like, they have no clue how to advise this woman. Everybody's talking about what to go take AAP, get your CPC. Well, you don't even know what she wants to do.
Mm-hmm.
You have to find out what is your end goal. Like,
What is
what do
the
you
end
want to do
goal?
with medical coding? Because
Exactly.
if she said I want to do inpatient CDI, CPC is useless.
Useless. A waste of her time, money, energy, all of the things.
Exactly. And then she been to spend all that money and all that time and then be dis a freaking pointed.
With a capital D.
Yes.
Emphasis on frick. Oh goodness. So
So I I try I tried to help. So I had to I had to set it up. So I said, fellow nurse and certified coder here. This is what you need to do. You need to figure out what it is your end game, and that will dictate your path.
mhm.
That's what you got to do first. You figure the rest out.
No, that's right. She said my answer to nurse contact, the coding nurse. That's it. That's all. That's right. Because I can't help you. I could teach you, but all that other stuff, I don't know. Y'all a different animal. Because I'm popping hands. Like, no, you are not diagnosing this patient. No, you are not treating this patient. No, because that's where they want to go. All right, all right. Okay. Well, thank you, both of you, for our on the street correspondent and Mr. Jesse for your church announcements. So today, let's get into this document. But I wanna start with some history, because this is not new. And again, every time we talk about compliance, I know y'all eyes glaze over, whatever, but it's important. It's like, yeah, I'm not tussling with nurses about coding at all. But it's important. And again, these are the guidances and the rules that kind of shape where we are and what it is that we're supposed to be doing in this profession. So first things first, the Federal Register. This is a document that comes out every day that lists information, all kinds of information from all federal organizations and departments. They talk about any new rules they have, they talk about any guidance that they have. And while we focus and look for stuff from the Department of Health and Human Services for the work that we do, all federal offices have a place in the Federal Register, and they come out every day. I believe they're free. I don't think you have to pay anything to get a list of what's happening in the Federal Register. So when you hear folks who are trying to, and oftentimes, they're first on the spot to be like, oh, so and so dropped, da 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 da. Now there are certain times of the year when certain things come out, and we know, and so everybody like looking every day, like, okay, when is this coming out? When is this coming out? And we, are mindful of that, so we can be the first ones. And this is when I talk about, putting your own eyes on what the rules are and what the guidance is. The Federal Register is where you want to go, or you can also go to the federal department that published the information. Said all of that to say that in 2000, so for at least 24 years, Thursday, October 5th, 2000 is when the OIG put out guidance for individual and small group physician practices. Now, while it's talking specifically to physicians, I'm going to expand this to any provider. These are the things you need to know. These are the things that you need to be mindful of if you are a provider providing services. Now, initially, and I said I was going to show my screen, and I will in a minute. Initially, this was a voluntary process. This was compliance plans were voluntary. You could have one or you cannot. You can follow the guidance or you cannot. But the game changed. And a lot of people don't know that the game changed. The game changed on these compliance plans being voluntary. I want to say in 2010, there was an act that passed that basically tells you if you are receiving or treating Medicare or Medicaid patients, you're required to have a compliance plan. So again, stuff that people don't know, stuff that folks just operating out here oblivious to whatever. They feel some kind of way that, this payer is asking me, well, why are they asking me for these charts? Why they want to see my documentation? Because they done already posted that, one, they have a right to do that. Even your third party commercial payers, in their contracts, it clearly will state that they will arbitrarily audit, double check, make sure they making sure that the money that they are spending with you that somebody else done put in is being spent appropriately. Government payers have always done the same thing. They monitor the spend. They're monitoring, making sure that things are adding up. I's are dotted, T's are crossed. So this is what the Federal Register looks like. Here. So this is a little glimpse of the particular Federal Register for the Office of Inspector General's guidance for compliance guidance for individual and small group practices. Now, notice they have all these pages. So this stuff been going on for decades, but and this one at least 24 years. And it gives you kind of a summary of all of the things that are required for individual and small group, and I will say providers. I won't limit it to physicians. I will say providers. I know physicians don't like this, but this information applies to all the people who are billing federal payers. They go into, the background. I know Kimberly Brandt. She's works in. She does a lot of work with HCCA, but she's also in the federal government doing. Well, I think she's still in the federal government. Well, she went to teaching. She's done a whole bunch of stuff. But anyway, she was here listed as the contact person. So she may no longer be that contact person because I don't think she's no longer working in that office. But yeah, you can still contact the Office of Counsel if you have questions or information. But anyway, all of this information gives you background on what the compliance program guidances are. Components of an effective compliance program. And these components are pretty much the same across the board. for all compliance practices. Let's see, there was something else. How to develop it back in September 8th, 1999. They were seeking all the information. They got 83 comments from various outside sources. They looked at all of the sources, decided, looked, had compliance program guidance and special fraud alerts, all of the things to actually come up with the information that is listed here in this Federal Register. So again, they break down the introduction. They tell you about the scope. Again, at this time, it was voluntary. However, based on the rule, and I'll show you, I'll go back and show you where that rule is that changed. It is now required if you are billing federal payers. So this is kind of the background information, the history information of where the information comes from for the compliance programs. However, the OIG also put together a roadmap for new physicians. And that roadmap, let me go back and tell you where. Go back and tell you where this came from. Doo-doo-doo. Okay, with the passage of the patient protection, this comes from the Office of Inspector General. Here, let me show you. Folks like to see receipts. Let me show you the receipts. Okay, so from the Office of the Inspector General, where they talk about compliance programs for physicians, very last line. With the passage of the Patient Protection and Affordable Care Act of 2010, physicians who treat Medicare and Medicaid beneficiaries will be required to establish a compliance program. Y'all see that? Okay.
Mm-hmm.
So if you click here, the compliance program guidance for individual and small group physician practices, that takes you to the Federal Register. But then they list, what are the components of a compliance program. This is under the OIG's roadmap for new physicians. It's the whole compliance programs for physicians. So you have the roadmap, which is what we're going to talk about today. And then different, it's broken down here. They also provide, if you are a provider or you work for a provider and want to provide additional information or education to them, you can find like slides. They have a full package, the slides that you can use to educate your providers on physician compliance. If you don't feel comfortable and you don't want to do it, there's a whole audio component. So if you want to take those slides, take that audio component, put it in your learning management system in order to have your physicians use it as their annual compliance training. All of the things are there for you to get this information out to your providers. But today I want to talk specifically about the billing components of the roadmap. And so this is what it looks like, a roadmap for new physicians, avoiding Medicare and Medicaid fraud and abuse. And the first several pages kind of talk about the fraud and abuse laws, which we've sort of talked about before: False Claims Act, Anti-Kickback Statute, Physician Self-Referral Law or Stark, Exclusion Statute. Remember, folks can't be excluded from the programs and bill, and that's an absolute no-no. So that's why folks have to check the exclusion list, both federal and state, for any folks working in healthcare, because if there's a person in healthcare working who is excluded, who bills, that's a problem. And then the civil monetary penalties law. and the amounts that come with that. But we're going to focus on the first section, which is physician relationships with payers. And so it talks about accurate coding, what that looks like, and all the things. So let's jump on. Can I click it and jump? Maybe. Look at God. All right. So, new people, new providers, residents, new physicians, all of the things. Again, you may not even be concerned about how your patient's care is being paid for. As long as you get paid, that's all you're probably concerned about. And that's fine. However, do know that there is a machine that's operating behind the dollar that you receive. There's a whole thing happening that is important for providers to know. It's, again, and I cannot stress this enough, especially if they are treating patients with Medicaid and Medicare insurance. It's imperative that you, because what is it? Is it not reckless disregard? Not basically not being informed and not knowing is not going to save you, because the information has been out there. So you have to know. So when they come and they knock and they listen to you like, yeah, and you've been working for how long? And you've been doing what for how long? Yeah, we have this guidance. So this guidance has been out here for at least 24 years. Somebody signed a contract on behalf of you, provider, your NPI number, all of the things. Yeah, somebody needs to know. So they hear you going on and begging for mercy and all of the things. However, they got receipts, they got the information, they got the documentation, and you need to know this if you are practicing. Mr. Jesse, you got your new nurse practitioners, you got the people who are out there who are they need to know this is what you're looking at, this is what you operated, this is your playbook, if you will, on how to operate compliantly in this field, in this game. I know we deal with managed care and they have run amok and doing all kinds of things, but yeah, this is your playbook. So let's start with so when the federal government covers items or services rendered to Medicare and Medicaid beneficiaries, then the federal fraud and abuse laws apply. So that's when we always talk about, the F word, fraud or abuse. And that's when folks' eyes get real big. Like, I didn't defraud anything. Oh, yes, you did. Because if you signed and submitted the bill and all of the things, yes, you did. So let's talk about accurate coding and billing. So again, so the payers expect you to make sure what you're doing is accurate. You are the first line of defense for what is happening with that payer. You tell that, or with that patient, you tell that patient's story. You're the one having the conversations. You're the one treating. You're the one doing all the things. And so it is imperative that that documentation supports and speaks to what happened. What was this like? What did you do? What did you need to do? What was going on with the patient? Why were they here? All of the things. Remember, we have the golden rule. We've had it forever. If it's not documented, it didn't happen. So all of the things, and for us in health information, that's kind of the law. That's like the Bible. So your documentation needs to tell the complete story. Again, you were the one with that patient. You're telling that story. You have to tell why. You have to tell the importance of why you need this test. You have to tell the reason why, the medically necessary reason for the additional services that may come with what's going on. Usually these things happen and this just goes on to talk about, the enforcement, how they can come after you criminally, civilly, administratively, all of the things. It says when you submit a claim for services performed for a Medicare or Medicaid beneficiary, you are filing a bill with the federal government and certifying that you have earned the payment requested and complied with the billing requirements. So, if you knew or should have known that the submitted claim was false, then the attempt to collect unearned money constitutes a violation. Period. Period. They talk about, upcoding, and these are some different ways in which upcoding exists. Typically, upcoding is, most people hear upcoding, they think evaluation and management services or E&M services, and those are the regular visits that providers have with patients, be it in inpatient. So when they're rounding and seeing the patient who's in a hospital, they are generating evaluation and management services daily. If you go to the doctor and have your, regular, uh, if you have a condition or you have something going on, you're generating evaluation and management services. Those are the services that the providers are providing. There's a difference between a new patient and established patient, and oftentimes, we have to play this game about, well, is this considered a new patient? Is this because new patients get more money because there's more time spent. They're just getting to know you. You're building the relationship. And so those new patients, again, that the fee for that is more. The cutoff is 3 years. So even if you've been to that provider, but it's been 3 years since you've seen that provider, then you then become a new patient all over again. And so at that point, they can now bill you as a new patient, which, you know, may change your copay, may change some different things for you. Just remember, go ahead.
No, go finish your.
Oh, I thought you were.
No, I do, but
um,
just finish your
okay,
thought.
okay. And so keep in mind, and then also there are some specialty requirements around that too. So if you are seeing, if you're new, so say you are seeing in a group practice and there are multiple specialties. There are some nuances and there's a whole decision tree for folks to understand. Are you a new patient to this provider, even though they're in a group practice? It depends on the specialty. It depends on there's some questions you need to ask before you say, oh no, I ain't never seen this person before. They're a new patient. They may not be. They may just be an established patient because they've seen somebody with the same specialty as you within your group practice. So again, all of that is part of understanding and being compliant with your evaluation and management coding rules. Go ahead, Mr. Justin.
And what a lot of people don't understand about that 3 year rule is it is it has no bearing on what type of insurance you had during that 3 years.
Mm-mm.
And I here in Philly, I went to this primary care clinic. I was paying cash. Then when I got insurance, I called to make an appointment. So they were okay, fine, no problem. They called me back and said that I had to change my appointment because I had to be billed as a new patient. I'm like, no. Mm-mm. And I told my I was just seen like last year. I said no. So she tried to tell me, well, this provider had never seen you before. I said, no, but she's at this practice. So this practice has seen me before. So I said, I'm not going to argue with you. So I go on the internet and I find the medical director and I just politely sent him a nice little letter, let him know, I'm not the one nor the two. And I can, I can have you, I can have your little practice all tied up for a good year trying to explain because they will go through every patient you have because y'all trying to commit fraud.
Mm,
But
absolutely.
people don't know that.
Absolutely. It's crazy out here, but it's real. The game is real, and again, knowing the rules, playing by the rules, is what's gonna keep you safe in this world of healthcare. Another thing that folks get in, and we've talked about this kind of in passing too several occasions, is modifier 25. Um, Folks, for whatever reason, will add that to every E&M service under the sun when they have a procedure happening just so that they can get both of those paid. But it's not necessarily appropriate for all of the things to get that extra payment because oftentimes the evaluation and management service is embedded into the procedure that you are having. And so if it's not separately, significantly separate and identifiable that it's separate, you're not supposed to be paid for that additional E&M that you think that you've added to your claim, because again, it's provided to you in the service that you had. There is a pre-op, there's the service, and there's a post-op. All of that stuff is provided. It's a global fee, and the E&M piece is in that global fee. So again, before slapping that 25 modifier on an E&M code, if there is a procedure and what you think may be an E&M, you must ask yourself, was this truly a separate service? And if so, can I defend this in an audit? Is there documentation to show that this was a truly separate identifiable service that warranted this additional evaluation and management payment at the same time of a procedure or service? So that's another thing that happens with up services or upcoding. Let's see, Crafty Coder has been going on and on. Let me see what she can do. These were the only things I needed to obtain my CPCO. I got once I realized offices needed it but don't have it. Literally, they have no plan whatsoever. I know they should, Clarice, but they don't. Well, that's on them, and that's the risk that they take. Like folks out here driving dirty, that's the risk they take. This is the risk they take to play in this particular game. They feel like they don't have to take Medicaid. It absolves them. Shaking my head. Or, well, it's Medicaid or Medicare. And then it's even further added with the managed Medicare or Medicaid. So the fingers extend a little longer because that's still considered their federal programs. Let's see, right now 25, when you said last week come in this week for XYZ. I think I understand that right now. Okay, so yeah, some of the things there, and here they talk, there's a whole special section with the caution tape that goes more in depth on coding for modifier 25, coding, upcoding, what that looks like for evaluation and management services. They give some examples of some fraudulent billing. Here's a psychiatrist. Again, this goes to any mental health provider. Fined $400,000 and permanently excluded from participating in federal healthcare programs for misrepresenting that he provided therapy services requiring 30 or 60 minutes of face-to-face time with the patient when he had provided only medication checks for 15 minutes or less. The psychiatrist also misrepresented that he provided therapy sessions when in fact a non-licensed individual conducted the sessions. Yeah, all of the things. All of the things. And even and if the person provided those sessions, there's a way in which you do that, because then you're the supervising provider, not the one providing them. And so you just have to get what their rate is going to be, but you're the supervisor. Yeah, it's a whole thing, and you just have to again play this game appropriately. Some documentation. Remember, documentation is your key to stay compliant. Good documentation practice helps ensure that your patients receive appropriate care from you and other providers who may rely on your records for patients' past medical histories. All of the things related to documentation, just make sure that you're writing it down. Make sure it's there. Medicare has specific documentation requirements. Even though CPT has specific documentation requirements when leveling evaluation and management services, the government payer also has. Sometimes they mesh and sometimes they play nice together. Sometimes they don't. So there may be additional requirements that Medicare or Medicaid may have that says, oh, I know you using this CPT book and this CPT code, or HCPCS codes, because people use those as well. However, we're requiring da 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 da. So it's cool that you can use them, but we have a different requirement. So, or an additional requirement. So make sure you are familiar with those requirements, particularly if you are billing services for Medicare and Medicaid patients. When you're enrolling as a Medicare and Medicaid provider with CMS, know that there's a whole other piece that happens. So you have an NPI, which is your National Provider Identifier. This is like your healthcare social security number. This is what links you individually to any documentation or any claims that you submit. They want to see the NPI when you are credentialing, when you are saying, hey, I am a provider and I want to be part of enroll in this insurance company or this insurance company or this insurance company. They're going, the first thing that they want is your NPI. It identifies you as a provider. All the information that you put in regarding your NPI talks about your specialty. It talks about what type of services that you provide, all of those things. So the NPI is important. Now, to your point, Crafty Coder, about people who say, well, I don't take Medicare or Medicaid patients. Oftentimes these third party payers will ask for your Medicare or Medicaid number because, again, it helps them understand and identify who you are and what type of services you provide. So if there is a problem, if there's something potentially going on, they can easily identify that based on any Medicare or Medicaid enrollment. So yeah. Also, prescription authority. You have a DEA number if you are providing any type of prescriptions. And remember, that number is a privilege, not a right. So never let someone else use your DEA number. Absolutely not. The folks out here going to jail for issues and problems regarding prescription pads, prescription, having pre-printed prescriptions, all kinds of stuff. So don't play with that DEA number. Did I say DEI? DEA number. Let's see. And that was the prescription authority thing. And then here's some examples here about that as well. So just remember, if you may be asking as a provider, how do I know if I'm coding correctly? You need to talk to your coder. You need to talk to the people who have learned how to do this work appropriately. They will be able to guide you in coding and billing for the services that you are providing. You should have knowledgeable people working with you, because at the end of the day, you provider are submitting this bill and you provider are attesting to when that claim hits that company, that insurance company, it is now saying, I attest that information on that claim is correct. And it's also attesting that I also have the documentation to support it. Again, it's one thing to send them claims out the door, but it's also a part of that process is to have the documentation to support it. So that's why your documentation is at the utmost important for you during this process. Some things that also can help, if you start with your documentation and then choose your code. Sometimes providers be like, well, I just, they got it in their head, all my patients are level 4s. And so I'm just going to, make sure I'm sending out level 4s and then try to reverse engineer that documentation. Well, please know that each patient is a unique patient, and each record should not look the same from patient to patient, or even within the same patient. That documentation should not look the same every time, because there's no reason why that every visit is a level 4 if nothing is changing, nothing is moving, there's no difference, there isn't anything that requires that level of service for that patient every time that patient comes. So there should be some variances depending on what's happening with that patient on that particular day, because you're basing the claim on what happened on that date of service with that particular patient and provider.
But
Um,
they seem to think that nobody can figure out but them that they're copy and pasting the same note. They, everybody else is an idiot. Nobody has enough sense to see it.
Absolutely. And that's the easiest thing that you could possibly see. Even your electronic, if most people are using an electronic medical record with the copy and pasting, all that is a report. You can run through that and it'll quickly tell you stuff that has been copied or things that they've seen over and over and over again. That's just a report.
When
So
I Go ahead.
go ahead, go ahead.
When I was working in CDI, there was a surgeon who I always had to send a query for this exact same condition almost for every one of his surgeries. And I didn't even have to change my previous query. I just had to change the person's name and the ID. The clinical piece, the operative note was exactly the same. I mean, when I tell you word for word,
Mm-hmm.
and it was wrong every time.
Oh my God. Other questions like what should I do if I find billing errors? Well, you need to stop incorrect billing immediately. Depending on what it is and how long it's been going on, you may want to seek some legal counsel so that it can assist you in what steps you need to move forward because there may be a repayment. So you may have to do a self-disclosure to say, hey, we found da 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 da, because it's better to tell them beforehand than for them to come after and they found it and now there's additional auditing and potential fraud and abuse types of situations going on that will require additional payment. So it's better to make sure that when you stop it, you seek legal counsel or counsel from a compliance professional or your compliance office or officer on how you need to move, especially if self disclosure may be in your future. Um, yeah. So again, I say this just to make sure folks know that this is a real thing. There is compliance. They give you guidance. They tell you what you can and cannot do. Every year when your new codes come out and information about the codes come out, oftentimes there's a whole federal register that's attached to that to say, okay, here's the additional information. This is why you need to do things this way. These are the bumpers, if you will, in how to operate in the sandbox. And so familiarize yourselves. Again, you can't just be like, oh, I didn't know. Oh, I didn't know. Well, yeah, you should have known. And Medicare and Medicaid definitely let you know because they send you all this information when you're signing up. Um, yeah, right. They do be trying to reverse engineer the codes. Um, they give you all this information when you enroll. They let you know, hey, make sure because you provider, it's not necessary for you to know, but it is important and it's your responsibility to make sure that you have someone on your team who is submitting on your behalf to know. Because again, ultimately, you everything that you do is at the mercy of that person who is submitting those bills on your behalf or submitting those claims on your behalf. So it's real important that you understand. And like I said, this particular roadmap, while today we just talked all about, the billing and documentation piece, there's a lot of information in there. We talked about those laws. Those laws are not to be played with. And not all of them relate to the billing services. There may be other things, receiving services, getting kickbacks, all of that stuff, all them little games that folks like to play. There are rules around that. And so making sure that you understand what those rules are so that you are playing any of these games appropriately is key to having a successful practice that stays out of trouble. How about that?
But I know we're at the top of the hour, but I honestly like this. Everything that we've talked about is 100% correct, but we know that the majority of people out there are not doing any of this. And fortunately for us, it will keep us employed because there are a
Absolutely.
lot of people. I think that there are two camps. I think there are some people out here who really don't know, and I think that this is a result of having your sister-in-law come and do your billing. and you just tell her what to do, and she has no clue. And
She
you
knows how to
know,
put the stuff in the system and put it on the claim and send it out the door, and y'all think y'all get the money back, so y'all excited like yay, and then ooh, because it might not
and
come back to you today, it might not come back to you tomorrow, but give it 2, 3, 4, 5 years, it may come back.
then you have people who know and have tried to have a conversation, but the providers, well, this is what this is what it's going to be. So you have people, and I get it. Like, you have there's it's a lot to go that goes into this, because not everybody is going to say, well, I'm going to take the high road and leave. Because some people, it's not that easy. So everybody, well, not everybody, but most people need a job to take care of themselves, and the need to survive overtakes the need to be compliant in a lot of these situations, and it just spirals out of control. And then when they get caught, everybody wants to play dumb, but everybody knows that this is how everybody knows how they got where they are.
Mm-hmm. But then when they take and permanently exclude that provider, you're gonna be out of a job anyway because they ain't gonna be able to practice.
But I'm talking about the billers and the coders.
If they're billing and coding for a particular provider who is excluded, they're not going to have a job anyway with that particular provider because there won't be anything for them to do. They won't
Right,
be
but
able to practice
Right, but at that point, then the biller and coder can go someplace else at that point. But
at that
you
point.
know,
At
mhm.
that point, but that should be a lesson as well. And again, as a coder, you operate under a code of ethics. So outside of even all
You
of this,
should.
you should be operating under that code of ethics. It's a whole thing that people try to be like, oh, I didn't know, or I didn't want to do. No, this game is real out here. And unfortunately, folks are jumping in it for various reasons. Oh, because I can work from home, or oh, because I want to get certified so I can make X amount of money. Well, with X amount of money comes X amount of responsibility, and folks need to understand the responsibilities that they are taking on when they jump over here in this profession. Somebody should be explaining that to them at some point.
but but they don't. I mean,
But you got a lesson
I
today.
right.
Act like ain't heard it if you want to. Oh, which I think is well, it's part of one of the differences between where you're getting your education. I think it's also part of that because again, some folks are just educating you for the information to successfully pass a coding certification or a billing certification, but not telling you all of the things that are historically part of how you got to where you are today in this profession. So I don't know.
But most people, you don't realize you got a bad education until you get out there. These people think they think they're prepared, and this is all you got to do. Then when they get out there, then it's when reality hits them. And I just it's it's a much bigger issue than I think anybody in health information wants to really say. And once again, the fault lies with the HEMA and AAPC, because they sell you the sun, the moon, and the stars. But when I tell you, them heifers are out of order, period, from the top down. And it's their fault, because they're supposed to be the overseers of the industry, and they have failed their members and the profession miserably.
So yes, they have. I agree with you as far as like marketing and not providing additional information about what's necessary in the profession. Where I disagree with you is the difference between AAPC and a HEMA, because we know with AAPC you could be any Joe Blow person off the street learning this information and go sit for a certification exam. Additional education is not required, and the education that is required, or the experience that is required, you could get that from anywhere. You could have been somebody that, worked your way up through the hospital, sat and learned and all of the things. And there are plenty of thousands and thousands of people who have done that and are successful in the roles that they have and successful in their certification exams. With AHIMA, they have the CAHIM accredited schools. And so getting your certification often requires, even though I think with the CCA you may not necessarily have to have any type of, or even with your CCSP you may not have to have any type of
For the CCS, it's recommended. It's not
it's
required.
recommended. You don't have to have that. But if you are a CAHIM accredited association or institution, then there are things that must be taught to all students in an accredited program. This is some of the things that must be taught. They teach you the law of healthcare.
Well, well,
They teach you all of those things in an
but
accredited AHIMA
right,
accredited, CAHIM
right,
accredited organization.
but the ethical questions are on both exams, Clarice, through both agencies. So I mean, that's not even the issue. The issue is it's not enforced. Yes, you can say, "Oh, well, this is what you're supposed to do." We all know that that's what's done. That there are ethical questions, compliance questions on every exam, AAPC
Correct.
or AHIMA. So,
Correct. And I wasn't
so
necessarily speaking
right.
to compliance. I'm saying they have
But
knowledge because they have learned this in the course. Whereas on the AAPC side, or any place that didn't have any type of structured education, unless someone brings that information into their course, i.e., me, bring it into your course, you may not know. You may not be exposed to that and not know how all this ties in together.
But see this is what, like, and I understand the whole K him, because because we always come back to this point. Like I get it. Like, I'm telling you, I was hired by a school that was K him accredited, that had a teacher teaching coding who was not even a certified coder. How was that K him accredited? There's no way in the world that, according to the guidelines, that should be. You're not
If that,
supposed to.
but no, you can, because you don't have to. If that person has a degree, did they have an HIM degree? I'll ask that.
No,
Okay, well then that's a problem, because
that's what
my
I'm
understanding was
telling
that they're
you.
supposed to have an HIM degree, because how how do you know coding to be able to teach it? So they don't necessarily have to be certified in coding, but they should have an HIM degree,
And I think that,
because
but
they
once
learn
again,
coding in an HIM degree. Not
but
to
I,
the
but
point
I,
of certification, but they learn
but I
coding.
also think that you should have to have a coding credential. That's just like somebody who who's a nurse teaching doctors. How
They don't
can
have.
you?
I know for certain they don't necessarily have to have a coding credential.
But I'm saying, but that's part of the problem, because I understand. Like, if you that's what like you have to have you have to know in order to teach, because the one thing about it, like, out of every place I've done a lot of schooling for various things, the one thing that I can say about nursing school is they prepare you. As horrible as some of those instructors are, as much as there aren't many nurses that don't hate their instructors, but you learn. I can honestly say, when I got that piece of paper and I started work, I had a clue. Now, of course, there are always going to be things you're going to learn, but as far as
Mm-hmm.
preparation, I was ready. And I don't. And when it comes to coding, I've seen it far too often. People have no clue, even the ones who are certified. Like, they can't even do a basic chart review, but you got all these letters behind your name. Like, that's a problem.
That's a problem. You're absolutely correct. That is a problem. That is a problem.
And the fault lies with AHIMA and
But what's the
AAPC, because they're
solution though?
supposed. The solution is to stop trying to go for the money, because I think they need to stop these asynchronous programs. You cannot learn coding on your own. I don't care how much you have these little courses on Thinkific and all that. That's not how you don't learn anything like that. I could never learn nursing being watching YouTube videos. It's not how it works.
Well, you know they have online nursing programs too.
But not that's only for for you have to already be an RN. That's for like BSN and MSN. That's all paper. That's fine. But the actual clinical component, no, it's got to be hands on. And I think that's the way it needs to be for HIM too. I think that they need to revamp these programs, and they need to have a clinical component where you are literally in somebody's office or somebody's hospital. That's the only way to really get it back on track, because it is the wild wild west out here.
Mm-hmm. It is. It is. And again, having multiple organizations out here with credentials, it's a crapshoot on what it is that you get, where you get, how you get. So, yeah, yeah. Do your homework. Do your homework. And providers, do your homework when you're hiring. Have some knowledgeable people at the door to verify and validate the people that you are potentially looking at to hire. You know, not just your wife or your sister-in-law or your cousin or your friend in them. Make sure that these people are well qualified to do what needs to be done for your particular practice. Because again, at the end of the day, you are the ones responsible.
I'm telling you, these practices are like outcasts. Me, you, and your cousin. Your cousin too. What is it? Me, you, your mama, and your cousin too. Yes, that's is
Yes.
all of that. All of that.
I have one of those shirts that says that. Yep. Never know.
And
All right,
and
all
it's
right. Go ahead.
and I feel sorry for some, because like I'm telling you, like when I read these posts in the medical billing and coding forum, I feel sorry for these people. I'm like, they are clueless, and they ain't got nobody. And you got it's just a mess.
It's a
I
mess.
I gotta
And
pray for them.
again, there has to be some sort of like solution to it all. Like what something.
Every solution starts with going back to basics,
There has to
because
be something.
it didn't start out like this. It evolved into this. It didn't start out like this. And they need to get back to basics. That's how you get it together.
Cool, cool, cool. All right, we done went way over
Ah,
time. Way. See how compliance rouse everybody up? Y'all be glazed over, but then when y'all hear this, wait, hold on. It brings out a whole different level of stuff. All right. So, are you thirsty for fresh perspectives on the healthcare revenue cycle and compliance? Like becoming one of the PRNT sippers, you join a community of sharp minds who savor the complexities of the healthcare revenue cycle. Why sip alone when you can steep in knowledge together? Come, let's spill the tea on industry insights. Now, here's what you can expect as a valued member of the Tea Sippers. Exclusive healthcare insights, so gain access to in-depth articles, webinars, and resources covering the latest healthcare trends, compliance updates, and revenue cycle best practices. Early access, be the first to receive expert insights and guides, ensuring that you stay ahead in the ever-evolving healthcare industry. Personalized support, enjoy direct access to our team of experts for guidance on medical coding, compliance issues, and revenue cycle management. We're here to answer your questions and support your professional growth. And then my favorite, community connection. Join a private community of healthcare professionals where you can network, share experiences, and collaborate on finding solutions to common challenges. So by supporting us, you're not only advancing your healthcare knowledge and career, but also contributing to the success of the Professional Reimbursement Network LLC, a resource that empowers healthcare professionals like you to thrive in their roles, goals, and dreams. So thank you in advance for considering becoming a member of the PRNT Sippers. For the cost of what, 2 cups of tea, maybe one of those little coffee drinks that y'all like so much, you can join the community. Check out the link in the description of the video or go to bit.ly/the PRNT Sippers for more information. Again, your support means the world to us, and we look forward to helping you excel in the world of health information and healthcare revenue cycle. Well, y'all, this was a good one. This was a good one. Thank you for joining us at the Saturday morning tea or checking out the replay. Let me ask you, was the tea spilled today? Put the teacups in the
Absolutely.
chat if the tea was spilled today. Now, before we sign off, as usual, I have a special request for all you amazing viewers out there. If you found this episode helpful, don't keep it to yourself. Share the knowledge with your colleagues by hitting that share button. And hey, why not subscribe to our channel while you are at it? That way, you'll never miss a drop of our health information, compliance, revenue cycle, and medical coding tea. And you alert all of the algorithms in the world that we're here and we're providing this information that folks need to know. If you have thoughts or questions or experiences that you want to share about today's topic, we'll love to hear from you. You can continue to comment. So drop your comment below and let's keep the conversation brewing. And if you have enjoyed this episode, again, give it a thumbs up. It helps more healthcare professionals find out about our content. And also, check out the Coding Nurse channel on YouTube. He spills some tea over there as well, especially you nurses and all of the things. I'm trying to keep my nostrils from flaring.
Yes.
Remember, at the Saturday morning tea, we're all about building a community of savvy, informed healthcare professionals. So like, share, subscribe, and comment. Let's grow this community together. Mr. Jesse, do you have any final closing thoughts?
Compliance is key.
Play with it if you want to. That's all I got. Play with it if you want to. So again, this has been a great session. For the PRNT sippers, we'll see you immediately after the end of this session. Check out the link in the Patreon. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Have a great weekend. Bye.